Hello, and welcome to the Senior Rehab Project, the podcast for the community of rehab clinicians working to advance care for older adults. I'm your host, Nicole, and this is the State of the SNF. In today's episode, we're going to begin our discussion on functional testing in the skilled nursing facility setting. But before we jump into that, I want to talk about our sponsor, the Academy of Geriatric Physical Therapy. They've been working hard to provide us Geri PTs with high-quality content to help us advance our practice. This year's Combined Sections meeting is a great example of that. The AGPT is offering 3 pre-conference courses in DC before CSM kicks off. This year, you can learn about the fundamentals of Tai Chi, how to apply a comprehensive approach to successful aging, or how to effectively manage kyphosis. And if you are going to that, I'd love to meet up with you and say hi because I'm going to be there too. All right, on with the show. I want to start by saying this is the first episode in a series I will be exploring over the course of 2019. It's not intended to be all-inclusive because that would take way too long for one episode. First, I want you all to think about the last eval you did. Which functional tests or tests did you use? And I'm assuming that you used at least one and that it was based on the patient. And I want to know also if you had to modify it, how you documented. So I know what you're thinking, and you are right. If you modify a test, it means it's no longer standardized, and the information that you can collect can only be used towards that specific patient that you are working with. It's only a reference for them and for you to check their progress at this point. It really can't be compared to the norms. But when you document, what you do want to say is how you modified it and why, so that everyone knows that you didn't get this score the way it was supposed to be done. You made some changes. These are why you made these changes. When I do this, what I'm really looking forward to is working with the patient and getting them better, obviously. But what I'm really looking to do is progress the patient to be able to perform the test correctly. And when I'm talking about this, 9 times out of 10, I'm talking about the 5 times sit to stand. So let's be real. In the clinic, lots of people who walk into that SNF need to use their hands. And I've had people say to me, once they use their hands, they fail the test. True. They have failed the test at that point. I still perform it. So like I just said, I have data to go back on. All right, so we're looking at a population in the SNF who probably has to use their hands or may even need assistance when they first get there. So sometimes I'm even helping the person a little bit. Obviously, if they are a max assist, I'm not doing this test. Clearly, it's not the right one for them. If someone's a max assist, I'm looking at something that's more going to identify their abilities with seated balance or the function and sitting test, something like that. That's where I'm going to go. So I'm looking at somebody who maybe is having some fear of falling or doesn't believe in their ability to stand up from the chair or is having some pain that they're afraid to work with, and maybe they just need a little contact guard or a little nudge to get themselves moving along with their hands. So again, when I'm saying modifying, I'm not applying this to like a huge group of things. It is still specified. I use it frequently, but it is still very specified. So, how does this work with the patient? Well, we just went over a section with Dustin where he was talking about making sure that the gains are something that the patient can actually see, correct? It's great for us if their score goes up by a certain number of data points. That's what we want to see. Patients don't care about that. But I'm guaranteeing you, if you take a patient who can't stand up from a chair without using their hands, and you are able to show them over the course of time that with some exercise that they can now stand up from the chair without their hands, or they can stand up from a chair not using their hands holding a small weight or any size weight or any kind of object, huge. You will see a physical excitement or reaction in these people because it's something that they didn't think they could do, and you've proven them wrong. They've proven their own preconceptions about themselves wrong. And I don't know about you guys, but that is a huge game changer in my patients. It's a huge game changer in their day because they've bought in, they've given me effort, and they've given me time, and they've worked so hard for themselves, and we've built that team, and they're seeing it pay off. And if that doesn't just make your day, then I don't know what does. So why did I choose to talk about the 5 times sit to stand first? Obviously, it's something I use very frequently in the clinic. And why do I use this one very frequently? There's a bunch of reasons. First of all, as far as some of the tests go, this one is so simple. It is limited space, limited equipment, right? All you need is a chair, a stopwatch, which for most of us is just the stopwatch function on our phones or our Apple Watches or our just regular watches that we've bought cheaply at Target because we're just going to destroy them anyway. And you need something to record each time trial on. That's it. It's something that the patient understands. Standing up from a chair is something that people understand, even if they're afraid of. It's something that they can conceptualize and they can understand what you want them to do, and you can get them to do that. It's been shown to correlate with knee extension strength across the lifespan. Factoring in age and gender may also be factors, and it has been normalized for body weight in a study that I found on the National Institutes of Health site. So it's open for everybody, and it's called the Sit to Stand Test, Performance and Detriments Across the Age Span. And they used a group that was 14 to 85, and they also looked at a subcategory of ages 50 to 85-year-olds, and they found this correlation across the board. It's been shown to have good retest reliability. It's been used in all-case mortality studies. It's been used with patients with Parkinson's and shown to be effective. It's been used in patients with venous ulcers and shown to correlate there too. So huge groups of people can use this. Very small amounts of equipment, time, space need to be invested in this. So it's a really good, just utilitarian test that is so simple to learn and something that's simple to do. It's also part of the short physical performance battery series of tests. And I know that's a big one in home health, and that's actually really easy to use in the SNF too. It's just a great battery of tests. It's right in the name. But it's a good group of tests. So it's been used in so many things. It's been shown to be reliable in so many things. And it's so simple to do and do properly. And it's also so simple to document your modifications. So for example, if I have, one of the first modifications that I usually try is to put somebody on a slightly elevated mat. So I start with a standard height, right? I measure the chair, measure the mat, I make sure they're the same height. And then I'll elevate the mat slightly if they can't do it, so that maybe they can stand up without use of their hands from a slightly higher surface. And I document the height of the surface. And then what is my goal? To start lowering the mat and to continue to teach them to do that. And there's different ways that I'll do that. Sometimes I'll add weights and do a weighted sit to stand at the higher elevation and then like work my way down. That's an easy, very, very easy thing to do. If I don't have a mat, or you have the chair, you use your standard height chair, you can try without hands first. Obviously, that's what we want. And then you can have them put their hands on the armrests. If you have the armrests, you can have them put their hands right on the seat of the chair if they find they need that push. So I just document, how was the patient set up? Patient was sitting on mat elevated to height of blah, blah, did not require use of hands at this elevation, but at standard height did require use of hands. Patient able to stand with hands on chair seat and perform the test, or patient required use of armrests to perform the test. I document all of this. I also do document age-related norms. I have a binder at work. It's really great. My boss, Sue, I love you. She She encouraged us to put it together one time when we had students, and when students are at that phase where they're doing well and you kind of have a little bit of free time, we sat down and we kind of put together a whole nice Bible, essentially, of tests. And we have age norms in there. We have it separated by category. It's really a thing of beauty. I'm completely nerding out over this right now, but it really is. And we have age-related norms in there. I pull that out. I say what the age norms are. I make sure that I'm talking about that this is without use of hands, and that's where I go. So that's how I would document. Literally everything I change is written down, and then what the actual test would look like, what an age norm score would be if I was able to standardize the test. So I have an idea of where the patient is and kind of what we're working for as an age norm. So even though it's not standardized, again, like I've been saying, it is my first point of data. It is my first point of reference for how this patient is currently and where we're going. And on that note, let's talk about how to actually do the test itself. All right, so I am pulling this directly off of the Shirley Ryan Ability Lab Rehabilitation Measures database. I love this thing. I access it a lot. I've had students access it a lot. So anyway, this is exactly what they say to do for test administration. The patient sits with arms folded across chest and with their back against the chair. With patients who have had a stroke, it is permissible to have the impaired arm at the side or in a sling. So there are some modifications already built in. Use a standard height chair with arms and keep the testing chair consistent for each retest. Chair heights recorded in literature vary, generally 43 to 45 centimeters. Again, note what you're doing here. Ensure that the chair is not secured. It's not against the wall or a mat. And this is probably one of the scariest things, especially in the SNF, because we're usually afraid the patient is going to use their legs to kind of pop up and just send that chair kicked back. So it's something that you have to remember, because I know a lot of times our default setting in the SNF is have that chair pushed up against something sturdy so they can't flip it over. Patient instructions. I want you to stand up and sit down 5 times as quickly as you can when I say go. I'm going to repeat that. I want you to stand up and sit down 5 times as quickly as you can when I say go. Your timing begins at go and ends when the buttocks touches the chair after the 5th repetition. You do provide 1 practice trial before measurements are recorded, because we don't want to take off points if they don't do it properly or if they have questions to ask you. I know a lot of times they'll get that, am I doing this right, in the middle of it? And then I'm like, well, yeah, you're fine. You have to sit back down before we do this. Inability to complete 5 repetitions without assistance or use of the upper extremity support indicates failure of the test, and any modifications should be documented. So it's not just me saying that we know they failed. Document your modifications. This is the recommended thing. We know they failed. Document your modifications. Document speed and assist level, contact guard, supervision, mod I, or independent in the PT standing balance section. Instruct patient to stand fully between repetitions of the test and not to touch the back of the chair during each repetition. It's okay if the patient does touch the back of the chair, but it is not recommended. It will actually slow them down. So if they're touching the back of the chair, it does take a little bit longer, so you're going to see an increase in time with that. Try not to talk to the patient during the test, because that may also decrease the patient's speed. And if you are concerned that the patient will fatigue with a practice trial, it's okay to do 1 or 2 trials first and not run through a whole session. Now, generally, they don't say anything here about how many times you do it. I was taught, and I generally see people do 3 trials, and I tend to give people, honestly, a minute in between, sometimes 2. I will time it just to make sure that they're not having muscle fatigue, which is slowing down their times. So those are all other things you want to take into account when you're doing this test. So we're going to come back to it. What I say is make sure you are doing a special test or multiple special tests that are appropriate for your patient at each evaluation. Make sure you're correctly documenting how you're doing it. That's the key, because that's your patient's individual starting point. Even if they cannot do it correctly in a standardized manner, document what happens, because that's going to give you somewhere to go with your plan of care. That's going to help you understand where your goals are, and that's going to give you a realistic picture of who your patient is and what they're dealing with. All right, we can't just go with range of motion, manual muscle test, sensation, call it a day. We have to be doing something functional in there. And that's the point that I want to make with this series. Not only do we have to be doing something functional in there, but I want us to be choosing it appropriately. And I want to talk about the tests and measures that we're actually using over the course of this series, so that we all are on the same page and that we are building, a profession where we're kind of, everyone's getting what they expect that they're getting here. Every PT practices slightly differently. I understand that. And we don't want to lose that, your personality, because that's what makes people connect with you. That is how you grow your client base. That's how you grow your patient relationships, is by being you and by allowing that to come through. But we want to make sure that people are getting high quality therapy and that we are being consistent with our outcomes, because you see the change in payment is coming. People are looking at this. People are looking at outcomes. People are looking at how they're paying us. People are looking at it. Are we worthy of this profession? Is this profession worthy of these things? We have to really be professional and show what we can do. So I want to thank you all so much for listening to the Senior Rehab Project and the State of the SNF. If you've gained from this episode, please consider supporting our work. You can become a patron through Patreon, a service that allows people like you to support people like us. You can give as little as $1 a month or become a game changer for $8.99 a month, where you'll get an awesome Redefine Old mug and access to our special Facebook group and all the cool things coming in 2019. Just go to seniorrehabproject.com to learn more and find the show notes for this episode. Talk to you soon, and I really hope I get to meet some of you guys at CSM. I'm super pumped to be going. I want to meet people. So Erin and I will be there. We look forward to it very, very much. Also, drop me some notes in the comments about what other tests you'd like to cover, what your thoughts are, what tests you normally use, and any thoughts or questions you may have, because I really want to open this up more as a discussion. And we'll go from there, all right? Don't forget, stay funky.